vascular access guided by ultrasound. Ultrasonography has changed the way we practice medicine, especially in acute care and anesthesiology. We used to rely a lot on our clinical senses, and shown here in this hospital ward during the chief physician's round, you can see just clinical examination, no technology, fair amount of medical students, only one female medical student, some people paying attention, a couple in the back, not at all. Today we're going to try to describe the use of ultrasound for vascular access and propose its rudimentary use for central cannulation and as a very useful tool for peripheral, venous, and arterial access. We're going to talk about complications, some ultrasound concepts, basic anatomy of the equipment, indications, human anatomy, uses, and some conclusions. On complications, there are many. I created a list of many of them, and it'll be interesting to just stop and read all of them. Some, like pulmonary artery puncture, I'll show a case of that, complication related to that. Others, like cardiac tamponade, which, it's a very important complication. But take a look at the list and just read them all. I'm sure I missed some, but all of these have been reported in the past. There is a case here of a patient who had a central line placed, in which the central line was placed into the spinal canal and chemotherapy was given, thus causing damage to the spinal cord. So this case actually happened, and even though it sounds incredible. There are many areas where we can cause damage with the needle and the wire, and just to kind of point to some of them in this chest x-ray. And just always remember, there are not where we can see just the needle, but the wire itself can be tangled and cause injuries to the heart or other vascular structures. This is a patient who had a central line placement and got hypotensive. Note the pericardial effusion post-placement. He was rushed into the operating room. He was going to have heart surgery, so a TE was placed and noted pericardial effusion with tamponade physiology. Sternotomy was done, and patient did well. It's another case in which there is a pericardial effusion that occurred post-placement of a central line via subclavian access. And in this case, the effusion is a little less obvious. The arrow points to the area of clotted blood around the heart. And it's important to note that when blood is clotted, it looks like liver. All this in red is the clotted blood around the heart. This patient underwent a sternotomy as they had arrested, and then a lot of clots were taken out, and the patient ultimately did well. A small puntiform injury in the pulmonary artery was noted and repaired by the cardiac surgical team. Another case of a patient in which a surface echo, a subxiphoid window echo, noted effusion post-central line placement. So as you can see, these are less common nowadays with the use of ultrasound as a primary tool. All these accesses have been done without the use of ultrasound. And the operators, of course, probably not completely attentive. Some basic concepts of ultrasound. We're going to talk about frequency, resolution. So higher frequency, higher resolution, but less penetration of the signal. So that's important. There are some ways, the more perpendicular to the structure, the better the image will come to the probe. And there is always some refraction of the signal, of course. But again, the more perpendicular to the structure, the better quality of the image that will be obtained. The more tangential to the structure, more waves are reflected away, less coming back to the transducer. And of course, there are always potential for refraction and artifact creation. Doppler could be useful also to analyze vascular structures. And the Doppler signal gets stronger the more parallel to the blood flow it is. As you can see, this is a very strong signal, described positively as the blood is directed towards a probe, and then totally, when the probe is completely perpendicular to flow, no signal is registered. And if we change the angle and the blood is moving away, we will see, of course, the signal inscribing below the baseline. Again, color can be used to identify vascular structures with flow. Some anatomy of the ultrasound equipment. There are different types of ultrasound probes. We have linear, curvilinear, and phase arrayed probes. For vascular access, primarily as a linear process, we want something with high frequency, even though they penetrate a little less, but we have a higher quality of image. curvilinear, mostly for abdominal exam, and the phase array for abdominal but also cardiac examination. So higher frequency in the linears, lesser penetration, higher quality of the image. The width of the ultrasound plane is usually a millimeter or two, so it's important to pay attention to that, as we can only see what intersects the ultrasound plane and nothing that is on the left or the right of the ultrasound plane will be seen. So the width of the ultrasound plane is very important. There are also many other ultrasound probes that can be used, from transesophageal probes, but the linear probes are what we use for vascular access, as shown in the circle. There are many machines, from bigger ones to more portable ones, and they can help for it could be used for vascular access. This is a probe, actually it has two transducers in one, and it can be selected a curvilinear and a linear one for vascular access. It's important also to clean the probe, as it is a potential for transmission of fomite, serous of fomite. Common errors and indications. Well, for evaluating vascular anatomy, a guide for insertion of lines, complications evaluation, assisting or other vascular cannulas and ECMO and heart surgery. It's important. One of the complications is not visualizing the tip of the needle at all times, and also not paying attention to the relationship between length of the needle inserted and depth of the vascular target. So it's important to know how deep our target is, to keep an idea how deep our needle should be placed in. So this is probably the most important thing. You have to visualize the tip of the needle at all times. You can use it for nerve blocks, and here you can see an inline approach in which you can see the whole path of the needle. And you can use this also for vascular access, although when you're doing neck lines, jugular vein, this is much more difficult. So out of plane insertions are done. Just showing nerve blocks. Here you have the subclavian artery, and you can see the depth. Again, try to keep an idea how deep your target is. Here's your brachial plexus in green, and here your rib, and then the pleura in white. So pay attention to the depth and relationship with other structures around to minimize your potential for error, and also know again how deep your needle is and how deep your target is. Some basic concepts of human anatomy. And one of them is also to identify properly. The artery and the vein can be compressed at different levels of pressure. If you can compress the vein, it's important. If you cannot compress the artery or the vein, they're most likely thrombose, or it could be a non-vascular structure if it's something deeper in the arm, if you're looking for a peripheral access. So again, non-compressible vascular structure, it's a sign that that structure is thrombose. In pediatric patients, a compression of the artery can be with such a small amount of pressure that it should not be misinterpreted as being a vein. And this is very important when you have a pediatric patient, a neonatal with a pressure of 60 systolic. So be very careful on that. Again, lack of compression, most likely thrombosis, or not a vascular structure. Now, as you can see, the relationship between the carotid artery and the vein can be the jugular vein in many positions in relationship to the carotid artery. And that's why landmarks by itself has a failure rate. It's also important to note that up to 18% of patients who had other neck insertions could have no jugular vein, and 1% of the population doesn't have a jugular vein, left or right. Here you can see the neck anatomy, and as we take away layers from the skin and the superficial muscles, the vascular structure is uncovered, and the relationship between other structures is noted as well. Always note how close the arterial and venous structures are one from another, and of course the pleura as you get down in the base of the neck. And of course the relationship between the artery and the vein changes in relationship as we travel from the top of the neck to the bottom of the neck. Note how the subclavian artery lays behind the jugular vein, lower in the neck too. So it's easy to go from the front wall of the vein to the back wall of the vein into the subclavian artery if you're doing insertion very low in the neck of a patient. So this is a very important image to always keep in your head. It's also been describing even punctures of the aortic arch attempting to do subclavian access. This is again internal jugular vein anatomy, and then you have a anterior jugular vein the left, the small blue one, and then the carotid artery. And I see how they, as moving down in the neck, you see the relationship between the artery and the vein and the sizes of the artery and the vein. And here we're very low in the chest, or I guess high in the chest, low in the neck. Red is the subclavian artery, white is the pleura. And then we're going to move back up and slide our probe towards the jaw in a second. We're still in the low portion of the neck, and you can see the vein. And now we're going to move up again towards the mandible. And you can see the thyroid on the left, and then the trachea. So the relationship of both changes. This is an interesting case. The right jugular is to the left and the carotid is to the right. And we're going to move from the jaw down to the base of the neck. We're going to compress first to show that that's a vein. And as we move down, you see how the jugular vein goes in front of the artery and then lateral. And then again in front of the carotid artery. And then we're going to move back up towards the jaw. So it is important that the vein can be in different positions in relationship to the carotid artery, depending on if you're looking up in the neck, mid portion of the neck, or lower in the neck. Also important to know that the carotid artery in an adult is always around 8 to 10 millimeters in diameter. So it could serve to give you an idea how big the vein is. So you can use the carotid as a size, a constant size, so you can actually use it to compare. So uses of ultrasound. You can do, always confirm that your ultrasound probe is well oriented. So I touch the ultrasound probe and I want to make sure if I touch the left, I want to see left in the screen. So do anatomical insertions. You can do an insertion in which the probe and the needle and the structure are aligned. So in plane insertion, or the structure is in short axis. So that could be, again, out of plane for the structure. And you can see the screen. So in plane long axis, or you can do also short axis of the structure, so short axis of the vessel or long axis. And that is important because for neck axis, sometimes there is not enough space to do it that way, so we end doing our out of plane, in which the ultrasound probe is perpendicular to the vascular structure, again in the short axis of the vascular structure, and the needle is also out of plane, so out of plane in short axis of the vessel. Here we have some images, and you can see how in the top is how normally the insertions are done. The bottom, you try to look at the whole wire in long axis, but it's very difficult to do, especially because you have the clavicle that prevents you to look distally. And it's important in short axis in the top, you can see as you move the transducer, you can actually explore the whole wire path. It's important to note that in short axis, needle or the wire, it looks all the same, so it's hard to tell where the tip is. The only way to tell where the tip of is moving the probe in and out, like in this example. So here we're going to depict a cartoon. You can see the needle, the skin, the transducer, the ultrasound plane, and the blood vessel. And to the right, the screen and representation of the blood vessel in short axis. Here we can see that the ultrasound plane does not cross the path of the needle, so we don't see any needle representation in the screen. Normally we should examine the whole structure, so moving the probe proximal and distal to it to examine the whole vascular structure to make sure there is no clots, abnormalities, any thrombus or narrowing of the lumen. We have a vessel that is long enough to take the line that we're going to place. And note a tilting of the probe actually to examine more distally, especially if you are against a clavicle. And here we're moving up. Again, we examine the whole structure to make sure there is no surprises. And once we're happy with the examination of the structure with ultrasound, we tilt the probe, and now we are going to insert the needle, goes through the skin, and we want to make sure we can see the needle crossing the path of the ultrasound. You can see the ultrasound hand moving to make sure we know where the tip is. The only way to tell is when you move the ultrasound probe towards and away from the tip of the needle, so you are 100% sure you're actually looking at the tip of the needle as you advance into the vascular structure. And in this case, you must have gotten blood return, and then we would proceed to put the line. So ultrasound jugular vein assessment is a case to follow. And here we see we're scanning the neck, you see the jugular vein at the top in blue and the carotid in red, again like a centimeter in size, 8 to 10 millimeters, pretty constant in the adult. And we're going to examine the whole vascular structure in the neck, moving cephalad towards the jaw. See in the anatomical and the patient live image on the right. So we're going close to the jaw, and the arrow depicts the jugular vein. And now we're moving down towards the clavicle. We examine the vein all the way. See, the vein is a little medial here. And in this case, the carotid joins the innominate artery very high in the neck. So this case was interesting because we could feel the pulse in the suprasternal notch, and we're moving the probe towards the suprasternal notch, and you can see actually the innominate artery in this patient right there in the suprasternal notch. And now we're going to move again a little lateral again, following the innominate artery. We see the subclavian artery in the bottom, and then the carotid. And the jugular vein is follow the artery. It's hard to see at this moment, but there you go. Again, we're now just above the clavicle. See how close the vein is. So it's easy to put, if you're in a lower insertion, you can go front wall of the vein, back wall of the vein, get into the innominate artery in this patient if we weren't careful enough with the use of ultrasound. Using the ultrasound does not preclude that you can actually puncture into the artery if you're not following the tip of the needle. And here we're scanning over the ribs. See how the ultrasound is pointed inside the chest. And we can see the subclavian vein. We can see the pleura to the right. We're now moving lateral to follow the subclavian vein. See a little valve in the subclavian vein there. And then we continue to move towards the subclavian vein. We can see the first rib, the bottom. So we have a very good idea of the anatomy of this patient. It should be no surprise when we try to access the patient, and we know what dangers lay ahead. So again, we're looking at subclavian vein, and now we have a little valve in the subclavian vein joining the jugular vein to become the innominate vein. And now we're going to start changing the angle. We're looking down actually still into the innominate vein. And now we're going to start to follow the vein cephalad. And now see the vein again, jugular vein, and you have the innominate artery in the back of this patient. You see the carotid emerging on the right, and now we're going higher in the neck again into this patient. So it's important to do a good anatomical scan on the patient. That way, again, we anticipate potential complications, the risks, moving it again towards the suprasternal notch, following the innominate artery in this patient. And it's important, again, physical examination and ultrasonography helps decrease, the potential risk of complications to occur. Playing this video clip a little long because it is such an important case, and how easy it is to make a mistake or have a complication. This will be a case in which you shouldn't, signals how easy it is by anatomical landmarks to actually potentially have a problem. Now we're moving up in the neck. See the jugular vein. We see an anterior jugular vein that is split a few seconds ago, and we see a nice compressible jugular vein moving higher up in the neck, close to the jaw. And again, moving down to the neck a little more. Again, a long clip, playing it back and forth just to underscore the importance of the finding of this patient. So you see the carotid and the jugular vein on this patient. So the next is arterial line insertion with the use of ultrasound. And you're going to notice how subtle movements. So that's the cephalad and then distal portion of the hand. That's the ultrasound probe. We're checking the position of the ultrasound probe to make sure left in the probe is left on the screen. So left is left, and you see my finger in the ultrasound screen. And then we have the needle. We see the artery. We put it in the middle of the plane. We make the depth the least possible so we can actually see the artery as clear as possible. You're going to see subtle movements of the hand holding the ultrasound probe, very, very slow. And the idea is to try to see the tip on the ultrasound screen. You see the little white dot is a disappear. When it disappears, it means we're actually looking at the tip. That's the tip right there. And then we advance slowly, and we remove our ultrasound hand is a dynamic one. It's moving slowly in conjunction with the needle, so we stay always at the tip of the needle. We're just slowly advancing our needle to insert it into the artery. We try to get to the front wall somewhat perpendicular with the needle, and then as we are about to enter, we will lay down the needle to minimize the chance of going through the back wall of the artery. So we are now tenting the interior wall of the artery. You can see we're in the center of the artery with our catheter, and we're laying down the catheter compared to our insertion. We're slowly advancing, making sure we see the tip at all times. We're just pushing gently and slowly to pierce the interior wall of the artery. And then once we get flashback, we'll continue to lay it down and then advance some more to make sure we have enough catheter inside of the artery before we slide. Note that the catheter is getting flattened against the head of the patient, against the hand of the patient. And we're looking at the tip, and our ultrasound hand now is dropped, and we advance the catheter as we are in this arterial insertion. So very slow. This patient had a prior access, and that's why the bruising in the hand, that's not our doing. Some clinical cases, a lot of images and clips. So here we have a patient. You have the thyroid, the vein, and the artery. And it's important to note that the vein changing with respirations is always a good thing. It means there is communication inside the chest. A vein that doesn't breathe or changes with patient's respiration probably means they're not good intrathoracic communication. And we see we're moving down in the neck. You see the vein, also Subclavian vein. And now we're moving up in the neck again. You see thyroid and the carotid in the back. Remember, carotid 8 to 10 millimeters in every patient. And that's again Subclavian vein joining the jugular vein. And then we're going back up in the neck on this particular case. Another patient. Again, we were scanning up and down. In this case, again, you see a small jugular vein and an anterior, it looks like anterior jugular vein as well. So 2 veins. And in this patient, we'll again scan. We're moving down towards the clavicle. And you see the vein is very lateral. And you see the subclavian artery, that arrow there, it's a ghost looking. Now very difficult to see here. And we're moving again back up in the neck. Note that the vein in terms of size and anterior posterior diameter is as big as a carotid, so it's a small vein. Another patient here in which you see a very, very small jugular vein. You see the thyroid to the left and the carotid, just a vein just on top, almost on top of the artery. So small vein. So this is important. This patient actually was just laying flat, so it's a low central venous pressure. We asked the patient to do a Valsalva now, and you see really the real size of the vein. That's important. Sometimes when you're putting a line, the vein looks very small. You can actually ask the patient to do a Valsalva, hold it for a second as you have the needle very close to it, and then you take a moment and just puncture the vein, put the wire in. If the patient is able to hold breath for 15, 20 seconds. Here's a patient with Trendelenburg position. Of course, you see a larger vein. Clearly, this patient has good communication with the chest from the vein, because you can see how it changes with respiration clearly. A vein that doesn't change with respiration or position, you have to worry that could be a proximal obstruction. Here we see a Doppler just showing the flow in the vein, and of course it's red just because of the direction of blood flow. Doesn't mean the red is arterial or venous, it's just direction of blood flow. Different patient with also another small vein. and the carotid in the bottom. Again, 8 to 10 millimeters of carotid. Another example of a small looking vein. But it's important when you see artery is always a good marker of size. Here a little thrombus on a different patient in the back of the vein. And this is a patient in which there is no vein actually visible. So it's important to, again, examine your neck, and then there is no surprises. A patient on the left and right side, you see different size of vein in the same patient. So it's important to know there could be anatomical variations from one patient or another. And here is a hematoma, and taken from this article, taking almost all the lumen of the vein, so we'll probably use a different vein. Here's a patient who had an arterial puncture. Patient was on access without ultrasound initially. The red and then the purple is actually hematoma after post-arterial puncture, and then the vein in the top. With ultrasound later, it was used, and a line was placed in this particular patient as there was no vein on the other side. This patient has actually no good-sized vein. Another patient with small clot or hematoma inside the vein. And this is a patient in which the image in the top is a large vein, all that in blue in the lines. It's just artifact. When you compress this vein, that was completely compressible. And that same patient with 2 wires inside the vein, the jugular vein, as he needed 2 central lines, and then the wires seen more distally. Another patient in which it was a hematoma in the vein, as the posterior wall was punctured. So it's important how to recognize this. Usually not a major problem after, just in the image you understand that this is hematoma in the vein of the patient. It's a patient with a complete occlusion of the vein because thrombos. And usually patients who had central lines before and they have thrombose line. And this patient who had a dissection, and you can see flow into one of the carotids, left carotid, and with some flow pretty narrow, and then the right one with at least a whole lumen with flow. There's other uses of ultrasound examination. With a little anatomy of subclavian vein and artery. Again, some drawing so you can see the relationship between the subclavian vein and artery. It's harder to image with ultrasonography, but with practice, it's also not difficult to do. And here you have the subclavian vein and artery. Here you see the subclavian vein. And you see a rib on the left and white. And sorry, that's a clavicle. And as you can see, the vein breathing, and that's normal. Subclavian vein. And slight movements of the ultrasound probe, you can see the subclavian artery. Now we will have the subclavian artery with the vein on top. So the clavicle in white and the vein in blue and the artery in red. And then the pleura just under the artery. And here you see how close, of course, one to another, vein, subclavian vein. And then with the probe, rotate a little bit and tilt it a little bit, you see the subclavian artery. So we're doing access with the use of ultrasonography. It's easy to do, but you have to be very careful. And this is usually an inline insertion or close to an inline insertion done. And this is a live demonstration of a central line placement. So you see checking the position, so left in the monitor and the ultrasound probe, and you see how the vein is compressible. Probably in this insertion we should have a little more depth on the ultrasound. And that's the artery, carotid, and then the trachea. It's always good to examine. Again, more depth should have been used in this particular case. It's a video taken a few years ago, so I have enhanced my technique since then. You're following, again, the tip. My hand is moving the ultrasound probe so we can see the tenting in the anterior wall of the vein. And sometimes you have to push a little more. There's always a risk. In this case, I went through the back wall. You can see that I pull back. Unfortunate, but sometimes the vein is too compressive when that happens. We got nice flow, and we advance our wire and this line. And the wire should go with 0 resistance. And then the ultrasound should be used to confirm the position of the wire in the vein. And you should examine by tilting the probe all the way and following the wire inside the vein and into the innominated vein. So tilting to see distal, and then you see the wire, and tilting some more and see the wire going inside the chest. Tilting some more and more. This case, it was incomplete, and probably someday I'll upload a better video so you can see the whole path. Again, as I said, I took this video years ago, and here we're putting a second vascular wire in this patient. You can see slow deliberate motions, a little lateral there in the vein, and we're tenting the anterior wall of the vein. And there we are entering the anterior wall, very close to the carotid, as you can see, but we have everything under direct visualization. And now, again, the same thing. We got into the vein, got flashed back, and then we put the second wire on this patient. So it is important always, once you put the wire, to follow the wire all the way down to make sure it's going into the innominate vein. It did not go, and here you can see the two wires. We're going to tilt down and follow the wires into the vein. See the two wires being pointed out there. And as we tilt the probe, angling so we can look inside the chest, you can follow the veins distal in the jugular vein. And again, we should have more depth on the ultrasound probe. So this was not appropriate. We should have probably 4 or 5 centimeters in depth so we could see better. We didn't explore well the wires into the innominate vein. So the technique should be a little bit better than this. And conclusion, there are you require experience, of course, equipment. You have to be prepared, understand you have to clean the transducer between patients' use. You also could lose the ability to place vascular lines without ultrasonography, and that's something always to consider. They are always good to assess the anatomy before sticking the needle, place the vascular lines under direct visualization. This reduces insertion attempts and reduces complications, and also helps you diagnose some pathologies. Well, I hope you have enjoyed the video, and thank you for your attention.